Welcome. So greetings. Today is Tuesday, May 7th. It is day 2 of the 12th Annual Symposium on Global Cancer Research. We are very excited to have so many of you here. I hope many of you were able to join us yesterday for Early Career Investigator Day. And I also hope that you had the opportunity to enjoy the networking and poster walk session before opening today here. So my name is Mishka Kohli-Spira, and on behalf of Dr. Satish Gopal and the Center for Global Health, our director, and our team here at the Center for Global Health and the ASGCR Scientific Steering Committee, it is my pleasure to welcome you to day 2 of the 12th Annual Symposium on Global Cancer Research. As I said, again, I just want to acknowledge the presenters and the team that put together the Early Career Investigator Day yesterday. And so I want to give them a Zoom round of applause for a very successful first day of ASGCR. For those of you who were with us last year, you may recall that we had for the first time, we had an open call for scientific sessions, along with our annual call for scientific abstracts. It was such a success, and thank you to the Global Alliance for Chronic Disease team for their collaboration last year. We decided that this year, all 3 of the scientific sessions that you will be seeing were selected through an open call and the peer review process led by our Scientific Steering Committee. In addition, and in response to the survey feedback, so yes, we do take your feedback seriously, we have expanded to have our symposium be a 4-day symposium, which will allow for 3 scientific sessions, and it also allows for an additional oral abstract flash talk session. So we will have 2 of those this year. We also are excited to share that we have a record number of accepted scientific abstracts, 146 to be exact. You are able to view them all in the Gather platform as well as on the website. And for the first time, the Rachel Perline Award will be given to a cancer advocate this year. Before we get started, I'm going to run through some of our logistics for today. You will have the sessions, the symposium itself will be recorded, and we will make the symposium recording available afterwards. We are keeping all of the attendees muted during the symposium. However, you can put notes into the chat, as you can see where the arrow is down below. And you can also adjust your audio settings with the arrow button next to the microphone on the bottom left and the video with the arrow next to the video on the bottom left as well. We also are very excited to provide simultaneous interpretation this year in French, Spanish, and in Portuguese. You will need to select your language of choice on the interpretation globe at the bottom of your Zoom screen. And we're very grateful to the interpreters who are working with us this year. So thank you for your work. Please don't forget to join us on social media. You can use the hashtag ASGCR24, and you can also tag us at NCI Global Health. It's now my great pleasure to pass the mic to my colleague, my mentor, and my boss to give today's opening remarks, Dr. Kalina Duncan, who is the director of the Partnerships and Dissemination Branch here at the Center for Global Health. And it's really under her leadership that ASGCR has grown and developed as it has over the past 5 years. You can read her full bio on the ASGCR website, along with all the other speakers. So without further ado, I would like to turn it over to you, Dr. Duncan, for your opening remarks. Over to you.
Wonderful. Thank you so much, Mishka, for that great and gracious introduction. And thank you everyone for joining the NCI Center for Global Health and our steering committee partners for the 12th Annual Symposium on Global Cancer Research. At the NCI Center for Global Health, we operate with the core values of collaboration, impact, and equity. The theme of this year's meeting, Collaborating for Impact, embodies the way and the why of the work that we do and support to ensure that global cancer research benefits people around the world. For the last 12 years, cancer researchers, trainees, implementers, and advocates have convened at this annual symposium to discuss the latest advancements in global oncology, to share best practices, to make connections, and to learn from one another about cancer research and the implementation of programs globally. For the last 4 years, we have convened virtually to allow for maximum access and minimum disruption as we come together to map out collaborative efforts that move the field forward. This annual symposium was originally a pre-conference satellite meeting at the Consortium of Universities for Global Health's annual conference. It has since grown to be an independent symposium and is currently one of the longest and largest annual scientific meetings dedicated to global cancer research. Over the next 3 days, we hope to satisfy many of the goals for this meeting, but a few I'd like to highlight here are to increase the recognition of global oncology as an important focus area within global health. This is something we must focus on if we are going to be successful in reducing the burden of cancer worldwide. Additionally, we hope that we will provide an opportunity for the real-time dissemination of research evidence with a real focus on highlighting work that is happening in and led by investigators in low and middle income countries. We hope to highlight early career investigators for recognition opportunities to advance careers and for mentorship opportunities. And as Mishka mentioned, those of you who were able to join us for Early Career Investigator Day yesterday were able to start the week with fantastic conversations about collaboration, initiating mentorship, and how we can work together to continue to build capacity for cancer research. And finally, over the next 3 days, we hope to listen to the needs of the global cancer research community to help NCI and our partners develop programs and priorities that are responsive to real-world experiences. So in short, we love this meeting and we so appreciate the opportunity to convene with so many of you doing such important work in global cancer research. If this is your first ASGCR, welcome. And if this is your 12th, welcome back. And I think there should probably be an award for that. We thank you so much for your time and your energy that you've brought with us in joining us today. And now I would like to turn to the amazing scientific steering committee who makes this meeting possible. Thank you to the steering committee member organizations and the individuals from those organizations who have served as reviewers and experts to shape the agenda. And I think we will hopefully be having a slide come up soon with their logos. You will meet many of these folks over the next 3 days in GatherTown and as they steer us through the meeting. A very special acknowledgement and thank you to the following partners who have worked so diligently with us this year. The American Association for Cancer Research, the National Cancer Grid of India, the Consortium of Universities in Global Health, the African Organization for Research and Training in Cancer, the American Society of Clinical Oncology, the National Network of National Cancer Institutes and Institutions, and the Latin America and Caribbean Society of Medical Oncology, RINC/SLACOM, and the American Society of Preventive Oncology. This partner list has grown over the past many years, and it is the breadth and diversity of experiences of those involved that allow for the wonderful diversity on the program that you'll see over the next 3 days. Moving on to our agenda and looking forward specifically to today, we will be together for the next 3 hours, including a scientific session directly following these remarks. We will then spend about 40 minutes back in GatherTown for an interactive poster session for poster numbers 28 through 67. We'll come back together for a rapid fire oral abstract session where we will have a chance to hear from 8 researchers who were selected by a peer-reviewed process before we close for the day. And now it is really my honor to introduce our first scientific session of the symposium. As Mishka mentioned, this year, for the first time, all of our scientific sessions are comprised of peer-reviewed submissions from you, the global cancer research community. I am so pleased to introduce our first session entitled Impacting the Cervical Cancer Burden in India, Collective Efforts and Strategies to Train Healthcare Providers on HPV Vaccination and Cervical Cancer Screening. The session is facilitated by Jennifer Conga, the Senior Director of Regional Strategy and Implementation at the American Cancer Society. Jennifer has spent the last 8 years leading work for the US National HPV Vaccination Roundtable and the Vaccinate Adolescents Against Cancers program. She is also an advisor to the American Cancer Society's global portfolio. You could read more about Jennifer and all of our speakers on the speaker bio page on the main conference website. Thank you again for attending today's meeting, and Jennifer, over to you.
Thank you, Kalina. Welcome to this session on strategies to train and engage healthcare professionals to increase the demand and uptake of cervical cancer prevention services. I am truly honored to represent the work of the American Cancer Society's Global Cancer Prevention Program, joined by our very esteemed panel of colleagues and partners in India. Cervical cancer is considered almost completely preventable, yet it continues to be the leading cause of cancer death in women in 37 countries. Nearly 960 women die each day of this preventable cancer, with 94% of those deaths occurring in low and middle income countries. The WHO Global Strategy to Eliminate Cervical Cancer outlines a roadmap for elimination. Without measurable action, the estimated deaths from cervical cancer in low and middle income countries will rise by over 50% in the next 2 decades. The American Cancer Society stands with global and domestic partners in endorsing the critical and urgent agenda of accelerating progress towards the reduction and possible elimination of HPV cancers. Our panel today is focused on work in India to increase uptake of cervical cancer prevention services. India bears 20% of the world's cervical cancer burden. Tragically, every 8 minutes, an Indian woman dies from this preventable cancer. There are more than 50 million 9 to 14-year-old girls who await HPV vaccination to be included in India's free universal immunization program. And fewer than 1 in 10 eligible women have received screening through the national screening programs. To accelerate progress, we need to develop and learn from the evidence on effective cervical cancer prevention interventions. Interventions which are created in and for low-middle income countries. The American Cancer Society's Global HPV Cancer-Free Initiative uses a research to action framework that is A, grounded in collective learning and co-creation of field-tested behavioral interventions, and B, prioritizes action to evaluate and establish effective tools and pathways to scale up validated interventions. Today, we'll be sharing a variety of links in the chat box with you on terrific resources to use and reference, especially this link on learning more about our processes and research to action framework. Partnerships begin with strategic collaborations. In India, we sought to center local cancer organizations where our missions align and where those organizations serve as local key relationship leaders. We sought to co-create the development, implementation, and evaluation of solutions with behavioral research experts. And we sought to support local system stakeholders in both public and private healthcare settings to increase uptake of cancer prevention services. Today's panel includes some of these key change agent leaders from a rich roster of talented collaborators on the ground. Strategic partners developed a shared understanding of barriers and facilitators to uptake of cervical cancer prevention services in India. During the formative research phase, healthcare professionals, including physicians and community health workers, emerged as credible sources to inform decision-making and were prioritized for intervention design and implementation. Here you see some of pictures of those cervical cancer prevention advocates in action. To reach physicians and community health workers, also known as ASHAs in India, medical societies and district health departments were prioritized as system stakeholders. Interventions with medical societies focused on HPV vaccination. Engagement with district health departments focus on cervical cancer screening. So with that, let's bring you the stars of today's panel. I'd like to welcome our distinguished leaders from 2 national medical societies in India. First, Dr. Priya Ganesh Kumar from the Federation of Obstetrics and Gynecological Societies of India. And secondly, Dr. Purna Kukare from the Indian Academy of Pediatrics. Joining them, we have 2 powerful leaders from 2 cancer organizations, Ms. Sutapa Biswas from the Cancer Foundation of India and Ms. Mridu Gupta from the Cancer Awareness, Prevention, and Early Detection, fondly referred to as CAPED. Our panelists today will be sharing their experience with establishing partnerships and training medical society member physicians, nurses, and ASHAs at primary health centers. We'll discuss some of the successes and challenges and their lessons learned when implementing evidence-based interventions. We invite you to post your questions for the panelists into the chat, and time permitting at the end of the panel, we'll address them. So I'm going to ask our speakers to make sure you're on camera. I've got 2 monitors, so I see you. Good morning, good afternoon, good evening, wherever you are in the world today. So Sutapa, we're going to start with you for the panel first and talk a little bit about translating formative research to implementation. So the formative research highlighted the importance of a strong healthcare recommendation to influence the uptake of HPV vaccination. How did the Cancer Foundation of India determine the right partners to reach among healthcare providers?
Thank you so much, Jennifer. It's a great opportunity for us to share the experience. We've been working on this with ACS since 2019. So it's a long journey that we've had with the formative research and then leading to where we are now. One of the challenges was that, when we started, there were so many societies and associations in India dealing with health. It was a huge list that we had, when we started, almost 70, 80. Those who have worked in India, they know that, India is a large country. So everything that you have is always large in terms of numbers. So we actually sat down and then sifted through it, created a checklist of what kind of organizations we would associate with. Would it be cancers? Would it be, the societies, the medical societies, cancers or health or HPV? And then we had a checklist and tried to think that which are the organizations with whom we can actually reach the maximum number of physicians. And that's where it narrowed down to, again, 3-4 associations, the top being the Indian Medical Association, where all the doctors of the country are registered. So then we again went down and said that let us go for specialization, not go for general physicians in the first phase. So then again, we had gynecologists and pediatricians as our final destination. Then again, there are a number of them, number of societies that are there. And that narrowed us down to the Federation of Obs and Gynae Society because, they are the ones of which most of the societies across the country are members. So to reach the numbers and to reach to remote areas of the country, the best way was to collaborate with a partner who has a link across the country with specialists. So naturally, FOGSI was the choice. But they are very, very large. They're 40,000 members. So again, the challenge for us was that would we be able to manage that because, large organizations have their own challenges, how they function. Then came the Pediatric Association. Again, we narrowed it down to the Indian Academy of Pediatrics. They're 40,000, more than 40,000 members now, actually. So they have another structure, but they have a lot of members, and these members are, again, across the country. So that was the primary way in which we identified and narrowed it down to the medical societies.
And Sutapa, how did you build and manage those relationships? And how do you keep the work moving forward in those partnerships?
When we started, when we reached out to these medical societies, we were assigned to work with the oncology heads. They have these different sections and different groups that are working. So we have two of our fantastic partners here and leaders they have been. And what was important is that as we were developing the different resources over time, we engaged with them. It is not that, we prepared everything and then said, here it is, and please start implementing it. So the long process of about 2 years or so, when we were creating the training modules, we were creating the resources, they were together with us, because anything that comes from the experts needs to be, again, Indianized. We have to see if they're culturally or socially acceptable or not. Scientifically, yes. So, which was a long process for us to go through everything that we had, and which I think built a strong base for us to start with. Because, they had understood over this period of 2 years what we were going to ask them for, where we are going to go. Of course, the oncology heads, and then you had the presidents of the associations. They were very, very, I think, focused on doing prevention work. The modules, when they received, they knew that the structure that we had, because, we had identified that we will do the training of 25% of the members, not all in one go. So that was one of the things. And the structure that we proposed to them, it worked for them. They said they can try. Because it's the first time we are doing this. Many a times the concepts are very good. But when you're rolling it out, for implementation in large scale, as we say, when you scale up, it becomes very, very difficult. So where you need a buy-in from each person in the chain. So we had terrific leaders in the oncology heads. We have Dr. Priya here, Dr. Purna. But I must say that, the leadership at that point of time of these two associations were extremely positive and very open to trying out something new. This was new for them, definitely new for them. They have never tried this kind of a training program of the members.
And that's a perfect setup for Dr. Priya. Dr. Priya, you represent FOGSI, which has over 40,000 physicians, as Sutapa just shared. Can you give us that high-level overview of how your organization structured the Medical Society training plan?
Thank you, Jennifer. And yes, FOGSI is a large society of around 42,000 members and around 267 societies. Now, they are all spaced across the country, and each society is autonomous. So it definitely is a challenge when we have to get these societies coming up under the umbrella and, talking the same thing what we want to. So now, as a gynecologist, we are the people who see the cervical cancers, and we are actually sensitized, We relate with the patients, and we also, we understand that this is a cancer which is actually can be prevented, Why should a lady suffer from a cancer? And that's why the FOGSI leadership also. Preventing the preventable was the main motto, We have been talking about this since long time. And actually in 2021, after WHO came up with 90-70-90 in FOGSI under the chairman, I am being the chairperson of this oncology committee since 21. We came up with SSNPP project. Now, this project also is somewhat similar. So we had already the system built in place in such a way that we had done certain CAP studies, and we understood that there are certain limitations, hesitancy by the gynecologist, because we are not primary vaccinators, right? We are all screening people, and the hesitancy worked out. And how do we actually cater to 9 to 14-year people? They do not come into our domain, but yes, we are the people who see them later on, right? So why can't we curb it at that primary level? So we did this study, and we did understand, yes, there is definitely a need for a proper counseling, for proper understanding the system, and more than that, remove the hesitancy enough to vaccinate. And we can be a good counselor, but the implementation of vaccinating, we can do it for PT, we can do it for DPT, or we can do it for influenza, adult influenzas. But somewhere down the line, we did understand that HPV vaccination is going to really create that buzz which really we wanted. Now came up the understanding was we did had the system in place, okay. We had divided, for the SSNPP project, we had divided India into 5 zones, and each zone had a zonal leader. And under the zonal leader, there were, each zonal leader had identified 25 to 30 members who are keen in taking this up as their primary motive. And also, we were talking about screening, we were talking about colposcopy, we were talking about preventing and all that thing, treating precancerous conditions. And of course, vaccination was a small part of it, just as a sensitization. But then when all the thing was happening, and we had gone through that system to the grassroots level gynecologists. Now, when the system was in place and it was already taking up a shape, and that's where the HPV project came up, and it was like a predestined thing for us. Our leaders were really, really happy, and we were truly happy to accept this project. And we did have a multi-tiered hierarchical system which was already in place. And we could actually enmask this system for this project, where there was a cascading, training program, like the core trainers training. We got a fantastic training from ACS group. I must agree to it. 30th May was what we had. 29th May, we had inaugurated this. We had a wonderful training from ACS team. And then from there, boiled down to us in each zonal, training their master trainers. Now, the best part of the success is when you actually give that semi-autonomy or the leadership to the zonals. All right. So the zonals were made the leaders. I mean, they really felt very happy, and from there on, they went on to train the master trainers. Now, master trainers were also thoroughly, the success lies in acceptance. The success lies in believing and accepting the novel ideas. We did calculate the risk. We had plan B, plan C in place. We wanted to give an absolute ownership to the master trainers so that they train their member trainers. Very happy to share that we have already touched the mark of 10,000 member trainers trained in a very systematic fashion with a very good prompts, monthly prompts coming up. Timely, generous appreciations was also given to them, like, on the bigger platform, like FIGO, bigger platform, like AOFOG, and their work was notified. Their work was fantastically appreciated. We do have a strong project manager with us who acts like a shock absorber, a guide, a friend, an analyst, a catalyst, thoroughly working across with us. And me as a national coordinator, I had the major role to play to see that everything runs smoothly. And I can pitch in whenever I really want to, see that a plan is not working, you put up the plan B. You have this, timely intervention. So I feel the timely intervention is the key to success.
Thank you so much, Dr. Priya. So that gives us a nice national framework. Maridu, I'm going to turn to you now, and I want you to share. With CAPED, you've been working at the district level, and you had to partner with the district health department. So I've got 2 questions for you. First, can you share how CAPED built trust and created a shared engagement plan with your district health department to reach healthcare providers in those primary healthcare centers?
Hi. Yeah, sure. So, in India, we have a very there's a very cultural concept in India that nobody wants to talk about anything evil because you invite it into your life. And cancer, nobody wants in their life. So there is usually no conversation about cancer. Nobody wants to hear. In fact, we are an implementation organization, community-based. So when we used to do these kind of talks in the village, if there was a pregnant woman or there was a newly married woman, they'd move her away. They'd ask her to go out of earshot because, you don't want to hear about cancer. So these conversations, nobody wants to do, not even government officials. Nobody really, it's no deep dive into cancer. It's always superficial on the top, need-based kind of conversations. So we realized that we are going to have to work with borrowed trust. And in villages, it is the Asha who the villagers trust. She's helped them through their children's health issues, their own health issues, family. So they have a lot of trust on the Ashas. And they trust village elders that we call the Pradhan or the Panchayat. That's where the trust is. So we had built a system early on where we would speak to the Asha and she would introduce us to the village elders. And from there, we would start working with the village. So it was a whole process that was created village by village where we had to earn their trust. So when COVID actually came in and all of this work was stalled, that's when the government reached out to us to create task forces for COVID. So we created task forces that went into the villages to screen them. We went to far-flung villages where we had a hold on community to screen them. And then later on, of course, for the vaccination as well. Mm-hmm. And in late 21, when COVID task forces were being dismantled, we proposed to them that we create the same model for NCD and cancer screenings. So our learning was from the field to theory, and then again from theory to field. So once we started to co-design it, we'd already built trust with the government now, because we'd shown them that the community listens to us and we can get difficult conversations going. And that's when we co-created the design for the cancer screening. And we found the gaps that we found when we were designing the program. And yeah, that's how the project started.
Thank you so much. Can you follow up by giving us your high-level snapshot of how the district implementation was structured in the 2022 project then?
Yeah. So when we started to co-design, that's when ACS came on board and we were validating them and doing gaps assessment. And there were multiple levels where intervention was needed, like the medical officers in the field were not trained for cancer screening. They didn't know how it was going to be done. The Ashas didn't really have enough information for demand generation, for community mobilization. So we had to bring this into the design module that we were creating, the technical training of the healthcare providers, of the staff nurses and the MOs. We had to do training for the ASHA workers to identify high risk, to do village mobilization, to bring the women for the screening. So, and once we did that, we realized there was no pathway to care that existed. So we had to create that pathway. The women who were screened positive, they had nowhere to go. So once these gaps were identified, we were bridging the gaps, and that's how we moduled the design. We went from village to village to build it, and now we are trying to build in sustainability into it and see if the government can take it forward without our intervention. That's the second phase of the project. But now that we've trained most of the ASHA workers and the healthcare providers, there is a kind of stability to the cancer screening model that's being implemented in the villages where we've already done the first round.
Great. Thank you, Maridu. Dr. Purna, representing the pediatricians, you've taken on this huge goal of reaching and training 20,000 providers with scientific HPV information and communication training. Can you share with us some of the successes and challenges you faced when rolling this out to pediatricians?
So thank you very much for giving this opportunity to share our experience of dealing with our pediatrician colleagues on this front. We started with Foxy for this, along with them, with American Cancer Society and Cancer Foundation India. And we also launched this program in the similar fashion, co-trainers getting training from American Cancer Society, followed by co-trainers training the master trainers, and then master trainers in each zone. Unlike Foxy, we have a hierarchical system. All 40,000 pediatricians are the member of Indian Academy of Pediatrics, with a central office which is guiding and navigating all the academic programs and the social programs. And there is a president and all the office bearers with the 5 zones which are existing geographical, and the 5 vice presidents. So we started our operation through our zonal vice presidents, who would oversee the whole project and take help of the master trainers to go down to the district, city branches. We have a branches of Indian Academy of Pediatrics to disseminate this program at the grassroots level. So we started off well, and we started in November, December, and it went off. All the trainings were mainly virtual, with very few being held physical. And this was a very good response. And then came the change of leadership in January 2024, when by calendar year, we changed all the office bearers and the executive board, which changed in, as you can see in this slide, our previous President, Dr. Upendra, he is taking the pledge, and all the pediatricians, there were 10,000 pediatricians who attended this national meetings each year. And in presence of them, we had this pledge being taken by all the pediatricians that they will take this matter forward. And we also had a very, very successful walkathon on 26th January, which is our Independence Day and Republic Day. And we had all the pediatricians participating and pledging that they would take this matter forward. And it has been since then little bit of slowdown, because as you know, pediatricians are very well versed with vaccination, and they have been in their practices advocating HPV vaccine. What we are trying to convey through this program is that those children beyond 5 years, like our target group is 9 to 14, they may fall off and may not have the proper communication. So you please ensure that you communicate well to the parents for the need of vaccinating their girls, and subsequently we will propagate it for the boys also, but just now we are concentrating on the girls. And also asking the mothers to get screened. So vaccinate the daughters and screen the mother. That has been simultaneously, because generally the girls are brought by mothers. At least mother is always there with the adolescent girl. And this is the message we are trying to promote, that vaccinate your daughter and screen the mother to achieve the WHO goal of 90, 70, 90.
Two sides of the same coin, right?
Mm.
Thank you. Dr. Priya, so we've heard that India will be adding HPV vaccination to the free national immunization program, hopefully in 2025. So as Dr. Purno was just saying, kind of keeping up that momentum after you've done this much training, can you share examples from your work in how you've helped build that momentum and sustain the project for cervical cancer prevention with FOGSI?
Yeah. So, what was happening was, we had started this program very well. It started creating a silent revolution. The healthcare providers started, understanding the capacity building. They understood the counseling. The main role came up was once the training program started and it was done, the trainings were happening daily, at least thrice or 4 times. Sometimes physical is happening. And our zonal leaders had to be on their toes, and myself to be on the toes to monitor this training program. Because this training program was a time-bound 2.5 hours with pre-test and post-test. Their timings had to be monitored. Their questions had to be, addressed to. What was happening was, by the time, by Jan and all, we definitely had huge lot of WhatsApp groups with that individual master trainers having their members into it. Post-training, many questions are coming up about the government policies, what's going to happen. So much inquisitiveness has come up. So we had to be on our toes, answering those questions, evidence-based, making them feel confident, the zonals feeling confident, the master trainers feeling confident that these questions are addressed scientifically. So invariably, as a national coordinator, I had a major role to play, to be on my foot, to watch those WhatsApp group and answer them. Plenty of questions pouring in. We can't allow the issues to fester, isn't it? We have to nip them on the bud. So what we saw over this phase, there was one challenge came up in our thing was, few of the master trainers, they backed out. Okay, there was a silence, sudden silence coming up. We had to then bring in new master trainers. That was a quick decision, a prompt decision taken up. And this decision, suddenly, within a week, we decided, let's change our policy. Let's go to the plan B. And putting up across those master trainers who couldn't come, unfortunately, due to whatever reasons, were again rekindled. They were brought back on the scene. These people who became silent was, replaced. And then again, this took our, of course, time and resource consuming, 24/7. I always say we are 6 group, 24/7, only talking about an HPV. So it was complete, but this saw the ultimate success. Now, there is a high coverage in the private sector. Members are able to catalyze out-of-pocket expenditure for HPV vaccination from the public. I mean, they are unprecedented. And monthly prompts are coming up. So the awareness level for HPV-related cervical cancers has overall increased, leading to increasing as well as screening. We are screening people, right? So mothers are getting screened, daughters are getting vaccinated. Limitations, definitely there are. Any huge projects does have their own limitations and own struggle. But we have to come beyond that, and I must appreciate my Foxy leaders. You can see over there on the screen, Dr. Rishikesh Pai. During his tenure, this training program started. There's Dr. Jaideep Tank next to Dr. Om. He's the current president. There was a smooth transition, extremely smooth transition, because in the core, we had already inducted people who are going to be the next presidents. So it was just a smooth transition for us, no hindrances. Leaders are absolutely fantastic in our Foxy. They really encourage such programs. And also these, you can see on this slide also, we did have building up momentums. We did have physical training programs, and physical training programs for role plays are excellent. We are seeing a lot of enthusiasm in Foxy. Their concept, of course, we all knew about it, but the concept of implementing, concept of, strong, now it comes as decision-making too. When a patient asks for the HPV vaccination, for their daughters, they're ready instantly. So we have seen a raise, and I'm really very happy for that.
Super. And those pictures just are so heartwarming to see the fruits of all of this labor and all of those champions out in communities.
Yes, and you can see that is actually into a medical college. And this medical college in Chennai, you can see the poster down on the right down. Now that's the students of the medical college pledging, coming up with their own fundas and slogans. It was truly heartwarming. And now this type we are seeing pan-India. So it's like a flare up of these issues, and we are happy with it.
That's
and
fantastic.
Definitely, this is a silent revolution helping government. We are also influencers, if you can understand, as a healthcare provider, you're influencers to the government rollout programs too. So that's happening very smoothly. Thank you.
And that's a great setup from Ritu. I'm going to come back to you around working with the government. So you've been working in districts in the Gurugram district, and now you're expanding work with civil society organizations to 2 new districts. You've got an implementation guide that your organization has created. So can you talk to us a little bit about the project components that were transferable and adaptable from the first phase to the 2 new projects? And what are your hopes for the future expansion of this work using the implementation guide?
Yeah, so everything that we used in the first phase, we put everything down. Everything is documented. So it's like a very easy implementation guide that any government or any CSO can just pick up and use. But we are still testing it. So if anybody knows India, you will recognize that we are really diverse. Even within the same state, 2 districts will not have the same sensibilities, whether it's cultural, social, religious. Even the dialect would be different. So it needs to be so contextualized for each district that we want to test it out a little bit more and see how districts are taking this up. So currently the 2 districts that we are doing, of course, there are some elements of the project that will stay will be standardized across all states. One is the leadership buy-in for sure. We need local CSOs who have community trust, who already have a hold on communities. The NCD project as such, the cancer screening project, is a central government project. So it has certain elements that we have to recreate everywhere we go. How we are going to do it could be different according to the states, but otherwise the elements of the project are the same. What is not transferable is the contextualizing of it for their geographies. For each geography, what needs to be done, how the ASHAs will be trained, what is the level of training for the MOs, the medical officers, the staff nurses, what is the capability, what is the pathway that will be created. That would be different for almost every district. Some districts have a district hospital that can do further diagnosis, some don't. They need to travel a lot more. How are we going to bridge that? So there are little practical issues that are not transferable that have to be solved in that moment at the site. But otherwise, largely, most of the things that we have put down, they are transferable. So if you look at it, we actually have checklists and things that each CSO will have to use in their geography. So it is constantly going to be a hands-on process if we are going to roll this on. And what we're looking at now is, of course, districts are implementation sites, and it's almost like, Lego blocks. So you just keep doing districts till you get the whole state. But there are other locations where we are looking at coming down state to district. So we are speaking to state governments and seeing if they can implement it across their states rather than going district to district. So when we are at the state level, for me, I think that would be the next phase, that the state government would take it on. And then we would be able to identify districts, and each district could support their neighboring districts, and we'd be able to, kind of build them up like building blocks and get cancer screening available to all the women almost.
And do you anticipate this guide being able to be shared in the near future?
Yes, once we've tested it across the other geographies, absolutely. And we'd want it to be so self-sufficient kind of a guide that anybody can pick it up and use it. But of course, these elements of building trust and working with the government will have to be, it'll have to be each person's understanding. But yes, I think this actually works across any geography or even any country in the end, because it just has a model of working with community and government. So that should be, it should be easily contextualized for other locations as well.
Great. Thank you so much for that. Sutaba, I'm going to turn back to you. So it's been just over a year since the rollout of the Cancer Foundation of India's partnerships with FOGSI and IAP in Mumbai. And there was an action guide created for medical societies to support this rollout. So for the folks on today's call, what would your key recommendations be to take this amazing guide and effectively put it into practice in their own context? What advice would you give them?
Before I give advice, I must thank both the leaders, Dr. Priya and Dr. Purna. It's so heartening to see them speak with the confidence and with the attachment to the project. It would not have been possible to reach wherever we have reached without them. Because, we can come up with great ideas, but that has to be rolled out. You need great leaders for that. The ownership that we always talk about, these are things that we talk about very, very often. But, seeing that happening for me, I was just sitting and watching them speak. I can't tell you, Jennifer, how satisfying it is to see that. Having said that, with the same thought, we have created this action guide. There are a lot of ideas that are given there. You don't need to do all. But depending on the strength that you have and what works in your community, because these are all practicing physicians, they don't have the time for doing campaigns. They would not be able to invest that kind of time. But what they can do, the power that they have, they could be writing an opinion piece in a newspaper. They could be part of a government committee where they can bring about change, or they'll be able to be a pressure group for the government at the local level. They could be creating more fact sheets, or the fact sheets or posters that we are creating as part of a resource. They could be using it and sharing it with their community. We are now having some of the resources in different languages, not all, but some of the major languages. So which then can be put up as posters in their clinics, there could be others beyond their membership whom they can train. They could be resource persons when the rollout actually happens. It is probably going to be through schools. Schools would require resource persons for the parents' programs. So they could be acting as resource persons. So there is the ample opportunity for them to pick and choose. As Dr. Purna said, they did a walkathon, as part of their large conference. That was huge visibility to the cause. Or when we had 10,000 IAP members together for the national conference, I think that was a great timing, and also all of them were together. So I personally feel that there are a lot of options that are there. So one needs to pick and choose as and when whatever works for them in their scenario.
Thank you for that. And I'm sorry, someone had audio on in the background. So if you're not one of our speakers, if you could please mute your audio. So we have a couple questions from the audience here. So I think we're going to turn to the panel. We've had questions about related to community trust and overcoming community and cultural barriers. Mridu, can you speak a little bit to how you engage with men and other cultural gatekeepers of women and girls' access to health?
So when I was talking about speaking with the ASHA and then getting into the village community through the village elders, usually India is a patriarchal society. So usually the elders would be men. The pradhan, the panchayat would be largely men, though you do see older women who sit at the panchayat and who are part of it. So once we speak to the panchayat and the pradhan, who's usually it's the local governance structure. So once we speak to them and we've convinced them that this is something that the women should have, I don't know of any village that has told us, no, you can't do it here, please leave. So eventually, in that engagement, when you speak to them, talk to them about the bigger area of cancer prevention and the fact that cancer can be prevented, that's something which is new to them. So once you've had that conversation, they are okay with you speaking, we go door to door. So they're okay with community engagement. So once we get into the community, then we look for the women, the mothers. We start from there, and then it goes to door health data that we collect and we speak to them. So it takes a while, and it has to be in a systematic way. I know if we had to just walk into a village and try and engage with them, we'd get thrown out. And in villages, if there is even one miscommunication or a bad comment, it spreads like wildfire. So it spreads like really crazy. So the minute we get in, we have to make sure that we already have the backing, we have the support, the ashas are there. The ashas know which women are really active in the village. So you've got to create that coalition, that support system before you even start engaging with community. That's worked for us in the villages. So I don't know where the person with the question is and if there's any other kind of a community engagement. For us, that has, it's worked to go through the ASHA and the village elders.
Thank you. Dr. Purna and Dr. Priya, I recall one of the presidents sharing that from a male physician point of view, he often spoke how fathers wanted to safeguard their precious jewels of children, their girl children. Can you talk a little bit about how you've addressed this in training with some of the male physicians?
Can I?
Yes, please. Priya, are you going to
Yes.
take it or? Okay.
Yes. So with a male, see, when we are having, this is for a healthcare perspective where we are actually talking for the training the healthcare practitioners, HCPs. So as a male physicians, of course, we have both the genders coming together. It's not only for the female physicians. So definitely we do have the male doctors coming up, the male gynecologists coming up. That's one part. The other part is the members who have been doing programs in the community. They are categorically seeing that, the male partners are also involved during the, counseling sessions. The fathers are involved when they're doing some school programs or the PTA programs. So these are the things which we took up to see to it that the males are getting involved. Maybe a physician or maybe a parent, or so that is where we took it up.
As far as pediatricians are concerned, there are many pediatricians colleague who are all male, and they are all pediatricians are highly motivated about vaccination. So their vaccination hesitancy is not there as a basic thing for the pediatricians. They are deeply into vaccinology. It is just we have to readdress the issue of HPV vaccination, which is not really in the net. On the contrary, we are trying to generate the awareness for vaccinations of all the children beyond 5 years of age appropriate vaccinations. And HPV is also going to be one of them, which we will stress. So between from 5 and 18, the age group which is still under pediatricians care, that is not being addressed too. And newer vaccines are coming up, and they have their own place, and age appropriate vaccination should continue beyond 5. So that is one of the things which we are advocating. And I would say that we have been thinking of creating a little different kind of an approach amongst the pediatricians who may not just like to listen about only HPV vaccine and just tag it along with many other vaccines which are age appropriate in this group, particularly beyond 5 and up to 15, so that we can make the HPV also as a part of it and make them aware of other vaccine also. And there may be more taker, and their acceptance and mind openness towards this whole approach may be much better. Male and female, I don't think it matters amongst the pediatricians, and they're quite open to talk about that. So that is not the case. Perhaps they may not be able to communicate to the mothers so well about the screening, which the gynecologist may able to do. So the details of screening and how appropriate they are, they may not be able to. So we need to further strengthen that aspects amongst the pediatricians about the screening. Also make them aware that only giving HPV vaccination and leaving the girls alone is also not appropriate. They have to get the screening done later on, because that message also has to be passed on. So this is the two approaches, and most importantly, taking the newer vaccinations also along with the HPV will make it more appealing to pediatricians.
And Dr. Purna, a short follow-up to that. How did you help make time in physician schedules and create supports for them to participate in training? Because we know physicians are incredibly busy. So there's a question from the audience around how did you help facilitate their participation?
At least I'll be very open about it, that initially there is a lot of enthusiasm, and virtual meetings are always welcome. People do join virtual meeting, but around 2/3 of them, they stick around. And 1/3 are, we are monitoring their timings also as to how much percentage of time of the whole module they are attending, just to get an idea. So that is what I said, if we tag it along with something which is very close and dear to the hearts of all the pediatricians, to learn more about the vaccines and newer vaccines and how they can be incorporated. So we are trying to do that, and I'm sure if you do that, virtual as well as physical training, both will become more interesting. So we are bringing little twist to the module for the pediatricians who may get bored with just listening to one HPV vaccine. So that part we are taken on now, because we have to serve to the needs of the people for whom it is meant. And I thought that we discussed a lot with the new office bearers and the new IAP leadership as to how we can make it more interesting and appealing to all the pediatricians.
Dr. Priyan Sutapai, I'm going to throw this next question your way. There's a lot of interest from the audience and learning from all your great lessons learned, which I know we have another slide on. But there's a specific question around if you encountered and how you dealt with the point of view from the Apex Cancer Institute in India and the Tata Memorial Center around questions about the safety and efficacy and cost effectiveness of HPV vaccination. This participant says that they're not sure that HPV vaccination is verifiably safe, effective, and cost effective.
Priya, ma'am, first.
Yeah.
Can,
All right. So first of all, effectiveness, yes, it is safe. One thing is, a lot of organizations globally has endorsed the safety factor of it. So there's no problem with it. And we all have started giving the vaccination. So safety is not the main concept. But when it comes to cost effectiveness, we are seeing patients at the age where, they are actually coming up with cancers in the country. As you just mentioned during your starting of your session, we did understand that India is at the helm. 20% of the cancers are coming up from global burden is from India. And this is the only cancer which is preventable. And the primary preventable part being the vaccine can be given at the early age, has seen a lot of benefits. I mean, of course, the huge cost which is going to be borne on treating the patient. And again, the emotional burden which is coming to their thing for, the family, everything is curtailed. Having said that, having a prevention with vaccination, yes, number one. Number two goes the screening. We cannot, the screening is again a very, very important tool when it comes to prevention. So for us as a gynecologist, we have been doing the screening programs quite efficiently so far. And yes, now our understanding from VIA, we are also shifting slowly as the WHO thing is to give a very high sensitive screening methodologies. There is a lot of awareness about HPV screening as a primary screening modality. Having said so, what happens in the gynec domain is the patients are very comfortable with us, and we would have delivered their children, right? So when the children come to the age of adolescence, of course, they do ask us these questions, ma'am, we are hearing about HPV vaccine, is it safe? So what we advocate is, you vaccinate the girl and you get yourself screened. So having said this done, this is somewhere cost effective. This is somewhere creating a great awareness in the country. So that's, and understanding the fact that vaccine is safe. So we are now very authoritatively, we are able to say that. Over to Sutapa.
Yeah. Jennifer, I want to add to what Dr. Shastri has asked. So if I may reply to you directly, it might sound rude, but we ignored. There's enough scientific evidence, and there was no need for us to follow what the Tata Medical Center says, because, there are a lot of experts around the country, and we have enough evidence, which is local also, in support of the vaccine. So I don't think there was a need for us to even address that. We did not address it at all. There had been sparks off and on, but it didn't really matter for us. So we took a stand on that.
Thank you, Sutapa. And kudos for that, he says, kudos.
We have been working for very long. He knows the history.
Rita, there's some other questions around screening in the chat, but we're a little short on time, and I want to make sure that we do a quick round robin. So I'm going to ask we go to the next screen, and if you have time afterwards, Marita, to answer any of those additional questions in chat, that would be great.
Yeah.
So I wanted to give all four of you an opportunity to share your parting thoughts on lessons learned after your multi-year, multi-partner, multi-sector experiences, and what do you think are the most important lessons learned from research to implementation for success? So if you could each, in about a minute, you have about a minute of floor time, just so we can share some tools and resources after you speak. What would be those big picture lessons learned that you'd want to share with this very interested research audience? Open. Marita, would you like to go first?
Sure. So I think for implementation, the project we do, it is stakeholder buy-in, whether it is at the government end or it is at the beneficiary end, we have to have buy-in even before we start, and communication. They're both very sensitive elements. Government, we all know how sensitive, community also very sensitive. So you have to have immediate redressal of any queries. Everything has to be in the moment, has to be immediately addressed, and has to be balanced. That balance, I think, is what creates the success of the program. For all those AI enthusiasts who say that AI is going to take your job, I would love to know how AI can take this over from you, because this is the big juggling that I think is what is required for success of this multi-stakeholder program.
Thank you, Mridu. Dr. Purna?
Yes, as I said, the lesson which I learned in navigating this project was that initial enthusiasm is always great, and you have to modify and be very flexible to the needs of the community that you are serving, my being the pediatrician colleagues, and their need to learn more about HPV along with other things. If we can satisfy, we will be more successful, and we are going to do that. Otherwise, they don't have to be convinced about HPV vaccination. They are already convinced, and they are ready to partner with us and go ahead and disseminate this knowledge. And everyone, those who have undergone the training, they have told that they have benefited a lot. Their misconceptions, a little bit of doubts there are all cleared, and they are taking it forward in communities. And the number of programs that we have at a social level is just amazing. And we are getting all the information which we are passing on to American Cancer Society through the prompts and to Cancer Foundation India, indicating that they are all the catalytic attitude, catalyst has been provided, and they are all now ready to jump into this program and take this HPV vaccination and screening in a big way. So I think this whole efforts have led to the readiness for the rollout of the government whenever it happens, either by end of 2024 or early 2025. The acceptance will be very big, and I'm sure it will help us in a big way.
Thank you so much. I love that catalytic attitude. You all exemplify that. Sutapa, what are your parting lessons learned?
Is that collaborations work. It needs that you are patient. It needs that you understand what the collaborator is thinking and create a win-win for both. If we are able to do that through the entire process, patience is very, very important, because it's very difficult. Sometimes you see it dipping so badly, you kind of feel like giving up, but you shouldn't. And also that, I personally have been working with HPV vaccination since 2008. So it's a very, very long journey for me. So it is not just, a job, it's my life's mission. So whatever I can do, I will do my best. So we as implementation or managers, our job is to think of what works, and then you're going to engage with, and how you keep that stakeholder engaged and excited through the entire process. Because as we complete this IAP and FOGC work, we move with the others, other groups. So we would hope that both IAP and FOGC, we have created enough capacity in them. They continue rest of the work with rest of their membership. We have trained 25% of the membership, and rest they can do it on their own. We move with the other groups. So collaborations work. This is a great learning for me. I have never done this scale of a training program with professionals at the national level, sitting in one corner of India, and you're doing that across the country. As Priya ma'am said, that you have a poster here and then banner there. It's very, very exciting. So if you come up with a good structure and know exactly who the collaborators are, and if you're able to create a win-win for both, I think that's the best thing that can happen. We don't have capacity for everything in one organization.
So true. Dr. Priya.
Yeah, the lesson learned is number one, believe in it. Have a complete faith in the system. and accept the novel ideas. Sometimes it is difficult when people see, we as gynecologists, we have obstetricians, and our people are on toes every time, running forth, back and forth. So every time, will that 2.5 hours work? Will we be able to sit? So this type of, that limitation which was coming in the mind, it's only a mind game. And if you can really reinforce, so that positive reinforcement, and getting our community work for it, making them the team leaders. Gynecologists now have started vaccinating their daughters and their granddaughters. So that has been the highest success which I have felt in our program, because many a times, even before this project, people used to say, oh, should I vaccinate? Now what's happening? They've already vaccinated. They're coming up with the videos. They're posting that into the prompts. And then they're confidently addressing to the patients, to their, ladies, that I have vaccinated my daughter, my granddaughter. Have you? So this is the success which I have felt is really happening. Positive reinforcement. I keep on telling all my team who all are working. There has been certain, we have to also, what I've understood is, as the leaders, as the national leader at me, managing this whole of the helm of the activity, what I personally learned was, be on your toes, look into all the groups, address the issues whenever anything has come quickly within 5 to 10 minutes, not giving them the whole time to speculate and come up with their own funda. So this is something which really I've learned. And that is the reason this time-bound program of, say, the actual thing started in the month of, say, what, August, September, we were on the foot till now. Of course, it is time consuming, but it's extremely rewarding when you see that the whole country is working. So I think it's the best thing which has happened to Foxy.
Thank you so much, Dr. Priya. Thank you, panelists. The enthusiasm is palpable. You are change agents, catalysts, and we are so excited about what's coming down the pike in India and our ability to eliminate cervical cancer. We know these projects have raised a lot of great, juicy research questions, so there's a lot of exciting things ahead for this work. But next slide, we want to make sure that you leave with information. Ashley, go to the next, there we go. Leave with the information on some of these great tools and resources you've heard about today. PreventGlobalHPVCancers.org has all of the information on the formative research, the action guides, some of the amazing handouts, patient-facing and provider-facing. You can grab it with your camera with this QR code. But mostly, next slide, we want to say thank you. Thank you so much to FOGSI, IAP, CFI, CAPED, and our funders. I also cannot leave without thanking the amazing ACS Global team led by the director, Minu Anand, program manager, Sarah Comstock, and senior program manager, Nina Batista, who do all of this amazing work with our partners in India. It is an honor to be with you all today. Thank you, NCI, for this invitation. And with that, Mishka, we give it back to you.
Thank you, Jennifer.
Thank you.
You all for your amazing presentation and amazing session. I hope you all are seeing the accolades you're getting in the chat as well. This has been a remarkable example of collaborating for impact, which is our theme, and grateful to have had your session here kick off the first of the 3 scientific sessions this year around that theme. So thank you for highlighting the importance that goes with collaboration, things like trust building, co-creation, political buy-in, all of those things, those very important concepts. So now we have all been sitting and observing and listening to this amazing session. I now invite you to electronically stand up and stretch your legs. We are going to wend our way over to the Meet the Abstract Authors interactive poster session. This is hosted on Gather. Hopefully you all have already had a chance to mill about in Gather in the networking and poster walk session prior to today's start, or even yesterday during Early Career Investigator Day. The link is going to be in the chat for you to join. This is a separate platform where you will be able to interact with all the posters. All 100+ posters are are there in all of the rooms. Today, we are highlighting the day 2 room, which is featuring posters 28 to 67. You can also find information at the help desk. If you're having issues navigating around Gather, go into the help desk area and they can help you. Because we're going in and out of one room in day 2 and the poster presenters are there ready to present their topics. If you have any issues getting in and out of the room, again, go to the help desk. You can also press the letter G and that allows you to navigate through people to get in and out of rooms. We're grateful for this opportunity to have multiple times to visit poster sessions throughout the 4 days. Again, as I mentioned earlier, we did this in response to the feedback from the community to allow for the poster presenters to present on certain days and then also be able to navigate. So you'll be able to go in and out of all the different rooms throughout the 4 days that you're with us. If you do have any technical issues, you can stay in Zoom and ask us here in the chat. Otherwise, we are going to put participants into the waiting room in Zoom while you are at Gather. We do ask you to come back promptly by 10:50 Eastern time to start the next session, which is the oral abstract flash talk session. It's the first of 2. We're very excited to share all of those presentations with you. So please make sure you're back on time, and we will start right on time at 10:50 our time. And with that, I will let you all go over to Gather and have a great Meet the Abstract author session. Thank you. Okay, great. I think we have a good critical mass here. I hope you all enjoyed interacting with the poster presenters at the Meet the Abstract author session in Gather. As a reminder, those posters are available throughout the entire symposium. You can also find them on the event website. And now I'm very excited to be able to invite you to the first of the 2 rapid fire abstract sessions. This one is focused on global cancer research. And apologies, let me just turn over here real quick. I'm going to immediately turn it over to our session chair, Dr. Maria Teresa Bourlon. Dr. Maria Teresa Bourlon has actually been a scientific steering committee member for ASGCR for 5 years now. She is also associate professor of medical oncology at the Instituto Nacional de Ciencias Médicas y Nutrición Salvador Zubirón in Mexico City. I'm very happy to turn it over to you now to lead our session. Over to you, Dr. Bourlon.
Thank you very much, Mishka. It is an honor to chair this rapid fire abstract session on global cancer research. I would like to remind you that this provides an opportunity for a diversity of researchers to present and disseminate their global cancer work to pertinent stakeholders. This really has become a foundational piece of each annual symposium on global cancer research. Given the record number of abstract submissions that we received this year, we have scheduled 2 oral abstract sessions, and I'm pleased to present these first 8 oral abstract presentations that were selected in a peer review process based on overall scope and relevance to priority topic areas of this symposium theme. The 8 presentations that we will see today cover global cancer research across cancer control continuum, from biology to etiology to treatment of cancer. I would like to emphasize the overall strength of all the submitted abstracts we received this year, and I encourage all the attendees to view the other 100 abstracts that will be presented on our website and on the poster session. And in addition, if you would like to see them again, they will also appear in a special issue of the Journal of Clinical Oncology, Global Oncology for July. I would like to let you know that this is a high-level rapid-fire abstract presentation. Additional study details are available on the poster, so please join us on the poster session if you want to see additional details of the studies presented today. Therefore, there will not be questions and answer session or discussion. Instead, we will motivate you to meet us Thursday in the author's poster session to meet the authors and be able to have an opportunity to ask your questions and discuss. You can find the full list of accepted abstracts on our event page, and I'm happy to start this session introducing our first speaker. Our first speaker is Gira Michelle Guevara Nieto. She's from Instituto Nacional de Cancerología in Colombia, and we're happy to see her work titled today, Transcriptomic Features Associated to Neoadjuvant Chemotherapy Response in 4 Molecular Breast Cancer Subtypes. Please, Dr. Guevara Nieto, we're happy to have you here today.
Thank you very much. I would like to acknowledge the Symposium's committee for this opportunity of presenting this project. This study has been funded by the Colombian NCI in association with LSU, the National University, and McGill University. So breast cancer is the leading cause of morbidity and mortality in Colombia, in women in Colombia and also in the world, which constitutes a major public health issue. Not all breast cancer patients respond to chemotherapy treatment, which suggests that there are tumor features that may explain the differences in response. As is shown on panel B, patients that achieve pathological complete response, they show improved disease-free survival. In panel C, which is shown a study in Colombia, shows that these patients from the Colombian NCI show a similar trend. So it is extremely important to detect biomarkers that would identify from the beginning of the disease which patients will not respond to chemotherapy and will have a higher risk of relapse. So the overarching goal of this study is to investigate gene expression patterns that are associated with non-response, emphasizing the role of genes, pathways, and variability among breast cancer subtypes. So as shown on panel A, there is an integrative transcriptome analysis that was performed from 53 samples from a cohort of female patients that belong to the Colombian NCI who were candidates for neoadjuvant chemotherapy. We analyzed only baseline samples, and these included 26 responders and 27 non-responders. As is shown on panel 1 to 4, the study comprised gene expression comparison, enrichment analysis, and tumor microenvironment estimation and therapy efficacy of target drugs using prophetic package. As you can see on panel 1, there are different gene expression profiles that distinguish responders at the light blue bar from non-responders from the orange bar among the breast cancer subtypes. The Venn diagrams below depict the common differentially expressed genes among comparison groups and oncogene lists taken from the OncoB database. I would like to highlight that panel 2, which shows the most significant enriched terms that included pathways related to the immune system. Regarding the tumor microenvironment in panel 3, we can see that the convolution analysis predicted different immune cell populations between responders and non-responders, also among response groups. And finally, in group 4, it showed that there is sensitivity to multiple potential therapeutic drugs that vary among responders and non-responders. So with all this briefly explained results, we found that there are genes related to the immune system, and there are diverse immune cell subtypes that were found among the tumor microenvironment that might relate to response to neoadjuvant chemotherapy. We have seen that there are significantly changes observed between response groups and subtypes. We have seen a trend that there are patients with high expression of these differentially gene expressed genes, which are also correlated with the oncogene list, might not benefit from this neoadjuvant chemotherapy. This might be a tentative first step prediction in clinical chemotherapeutic response that has been developed using these populations' gene expression data. And these findings underscore the importance of studying mixed populations to uncover novel insights and address disparities. Additional analysis, which might include quantitative PCR, immunohistochemistry, and functional analysis using in vitro and in vivo models, are needed to complement this data. And this study shows that there's a relevance of elucidating mechanisms that allow, that address therapy resistance, as well as selecting patients that will likely not benefit from neoadjuvant or will likely benefit in our Latino Colombian population. So for more information and contact, please scan the QR code and visit the poster 107 on May the 9th. Thank you for your attention and interest.
Thanks so much for that wonderful participation on such an important topic that is breast cancer on a global oncology perspective. Our second speaker is going to be Dr. Venkatesh Venharash. She's from University of Nebraska Medical Center in the United States. And she's going to talk about unique glycosylation pattern governed metastatic organotropism of pancreatic ductal adenocarcinoma. Please welcome to our session. We're very happy to have you today.
Thank you, Maria, for the kind introduction. So as Maria mentioned, I'm going to talk about how a unique glycosylation pattern can govern metastatic organotropism in case of pancreatic ductal adenocarcinoma. Next slide, please. So starting with a brief introduction of glycosylation. In the spectrum of metastasis, at every point, either in signal proliferation or else through intravasation, using the endothelial cells, the glycan structure plays a huge role. Here you can see these glycan structures are made by the functional molecules called glycosyl transferases. Our lab has been studying glycosylation, glycosyl transferases, and pancreatic cancer for past 2 decades. This is one of the study from my lab, which shows the differential expression of glycosyl transferases between normal and tumor condition. So this clearly indicates there is involvement of major glycosyl transferases in case of the pancreatic ductal adenocarcinoma progression. Okay, among all other cancer, why pancreatic ductal adenocarcinoma? When you start to check the 5-year survival rate of different cancer, the pancreatic cancer shows one of the dismal survival rate of 12.8%. Still, when you start to split up between the localized and metastatic conditions, the metastatic survival or the 5-year survival rate reduces down to 3.1%, which clearly signifies how the metastasis is actually important for further probing. When we started this study, we started to develop or utilize this metastatic models by using the pancreatic cancer cell lines. We injected these pancreatic cancer cell lines and enriched liver or lung metastatic cell lines, and we further enriched them using the in vivo models. After enriching these metastatic models, we started to check the expression of glycosyl transferases between the metastatic models that we used and also the primary cancer cell lines. It is clear that in case of the liver metastatic cell lines, we can clearly see the higher expression of GCNT3 and lower expression of P3GNT3. These two are the specific glycosyl transferases that we are concentrating. And in case of lung metastasis, this expression was actually reciprocal, where B3GNT3 is upregulated in case of the lung met condition and GCNT3 is downregulated in case of lung. So this PCR array data, we wanted to validate further. So we used digital droplet PCR, where you can see the absolute quantification of GCNT3 or B3GNT3. Here you can see the liver metastatic cell lines shows higher expression of GCNT3 and lung metastatic cell lines shows higher expression of B3GNT3. After confirming this at RNA level, we went further and proceeded to check at the protein level. In case of protein level also, we could able to clearly see the expression pattern of GCNT3 and B3GNT3 as we saw in the RNA level. So it clearly signifies there is an clear glycosyl transferases gene expression, which is actually changing according to the organ-specific metastasis. Next slide, please. Although we checked those using the 2 different metastatic cell lines, there is always a catch. This difference in glycosyl transferases expression that we are seeing could be because of 2 different cell lines that I used. So we prepared second metastatic model by using single pancreatic cancer cell line and developed a metastatic lung and metastatic liver and further validate all those expression pattern. So same kind of the expression pattern was actually observed between the metastatic and lung and liver in second metastatic model also. Next slide, please. After confirming all this data with in vitro and in vivo experiment, we wanted to correlate clinically. So we utilized some of the samples from University of Nebraska Medical Center Rapid Autopsy Program, where we collected the lung and liver metastatic human samples. We could able to see the same kind of expression pattern where GCNT3 is kind of upregulated in case of liver metastatic cell lines, where the B3GNT3 is upregulated in case of the lung metastatic samples. After confirming it with the IHC and IF, we could able to clearly see that the PDAC patient samples also underscore the clear clinical relevance of the glycosyl transferase expression, and this could be a potential to combat the pancreatic cancer metastatic regimens. Overall, our idea is, in case of the heterogeneous pancreatic tumor, there are subset of the cells which highly expresses this kind of glycosyl transferases, for example, B3GNT3 or GCNT3. The cells which highly expresses B3GNT3 are prone to show the core 1 extension in case of the glycoprotein, which makes them too susceptible to live in lung metastatic environment. In case of another subset of the cells where there are high expression of GCNT3, prone to form the core 4 extensions in case of glycoproteins, which makes them susceptible for the liver-specific environment survivability. We are currently concentrating on what are the glycoproteins that these glycosyl transferases are actually implicating on and how they are actually delineating the lung or liver-specific metastasis. With that, I would like to acknowledge my lab and other lab members for their constant support and engagement. Thank you very much.
Thank you very much for such a wonderful insights on such a difficult to treat neoplasm such as pancreatic cancer. We're moving over to our next presentation, which is a very common cancer in men worldwide, prostate cancer. Our next speaker is Rocío Senyuk from Argentina, and she's going to speak about deciphering the nuclear role of heme oxygenase 1 in prostate cancer, transcriptomal reprogramming, and neuroendocrine differentiation. Welcome, Dr. Senyuk. We're happy to have you here.
Hello, everyone. Thank you for the presentation. Well, today I'm going to be presenting this work entitled Decoding the Non-Canonical Functions of HO1 in Prostate Cancer, a Nuclear Perspective and its Association with a Neuroendocrine Signature. Next, please. Well, this study probes the role of hemocytinase 1, from now on HO1, and its nuclear interactors in prostate cancer. HO1 is a rate-limiting enzyme in heme degradation, and we have previously shown that the anti-tumoral role of HO1 in PCA and its nuclear translocation, hinting at its potential regulatory roles within the necklace. Thus, we postulate that HO1, alongside its interactors, can reprogram PCA cells to a less aggressive phenotype. Next. In terms of methods, the in vitro experimental design entails treating PC3 cells with hemine, which is a specific HO1 inducer, differential nuclear cytoplasmic protein extraction, and co-immunoprecipitation. The aim was to capture HO1 and its interactors for subsequent identification through mass spectrometry. The in silico methods include interactome identification and analysis and transcriptomic analysis in a preclinical model. Next. The Venn diagram represents the 44 proteins identified in the nucleus of PC3 cells and the 11 differentially enriched proteins found in PC3 nucleus treated with heme. This is the list of the 11 enriched proteins. Next, please. And since we know that HO1 doesn't bind to DNA, and to explore the biological relevance of HO1 in nuclear interactors, we analyzed chromatin immunoprecipitation data available in the public repository CHIP Atlas and enriched biological pathway data. The analysis demonstrated that 4 of the 11 interactors of HO1 were reported as potential transcriptional regulators. Next. And these interactors were found to bind genes enriching processes related to histone modification, methylation, acetylation, and transcription termination. Also, KEK pathways link these genes to diseases as Parkinson, Huntington, and Alzheimer. Next. So, as a conclusion of this part, we can say that HO1 nuclear interactors, have binding sites in promoter genes, in promoter regions of target genes, in genes enriched in processes that have roles in gene expression regulation, and that KEK pathways link these genes to neurodegenerative diseases, mirroring the neuroendocrine phenotype in advanced PCA. Next. To elucidate the association of these factors with the aggressive phenotype of PCA, we analyzed RNA-seq expression data from the MDA PCA PDX series from the MD Anderson Cancer Center, which captures PCA heterogeneity. We performed an unsupervised clustering analysis for the 11 HO1 nuclear interactors, and this heat map represents the transcriptomic profile of the PDXs, revealing that samples with high expression of HO1 nuclear interactors are associated with a neuroendocrine phenotype. It's also interesting to see that HMOX1 is downregulated in these samples, leading us to ask if HO1 is capable of halting the neuroendocrine phenotype. Next, We then perform a new unsupervised clustering analysis, but this time including HO1 interactors target genes found in T-bag dust. And the results show a better clustering of the neuroendocrine samples. So now we would like to assess if HO1 can modulate the downstream targets of its nuclear interactors, but we first have to validate the interactions between HO1 and these proteins. And we will start with the 4 we know that have target genes related to this neuroendocrine phenotype. Next. Thank you. Well, and as final remarks, I would like to say that we described 11 novel HO1 interactors in prostate cancer cell line, working with endogenous protein and nuclear cell extracts. That 4 of these 11 interactors have been already reported as DNA binding proteins, and that nuclear HO1 interacts with proteins that are associated with a neuroendocrine phenotype in prostate cancer. Next. Thank you very much for listening.
Thank you very much, Dr. Sanyuk, on such a remarkable work. We're moving to our next poster session, which is genomic and immunophenotypic characterization of conjunctival squamous cell carcinoma in a sub-Saharan African cohort suggests a role for immune checkpoint inhibitors in locally advanced or metastatic patients. This will be presented by Dr. Bida Esmaili from MD Anderson Medical University from USA and Ethiopia. Welcome, please.
Yes, thank you very much for including this presentation and the session. I am an ophthalmologist at MD Anderson Cancer Center. This is a work in collaboration with our colleagues at Mekelle University in Ethiopia. Next. Conjunctival squamous cell carcinoma is squamous cell carcinoma of the ocular surface. And in the United States, the estimated incidence is about 1 to 2 persons per 100,000. Whereas in sub-Saharan Africa, the incidence is estimated to be at least 10 times that. And the usual risk factors that we think of are sun exposure, light-colored skin, interestingly, chemical exposure, organ transplantation, HIV, and other forms of immune compromise. In sub-Saharan Africa, this particular cancer is a major cause of ocular morbidity, facial disfigurement, and metastasis, whereas in the United States, it's completely surgically curable in the overwhelming majority of patients. Surprisingly, what really piqued my interest a few years ago about this particular cancer in Africa was the incidence in some countries, in some African countries, conjunctival squamous cell carcinoma is in fact the 3rd most common cancer in women, possibly after cervical cancer and breast cancer, which is really remarkable because in the US, this is really surprising for us because it's considered a relatively rare cancer of the periocular region. Next, please. So these are some presentations for those of you who have never seen this cancer before. These are some presentations of squamous cell carcinoma of conjunctiva, the way we see it in the Western countries. In the US, mostly we see it as relatively limited growths on the eye surface. They're still quite important in terms of threat to vision and integrity of the eye. You see various different examples of these growths. They can occur on the eye surface. They can occur onto the corneal extension onto the cornea. It can occur on the inner surface of the upper or lower eyelid and or near the lacrimal drainage apparatus. So these are the sort of typical presentations in a typical US practice. Next, please. But now let's look at this presentation. This is also one of my patients at MD Anderson. This is what we would call a locally advanced and really aggressive presentation. This happens to be a case of a neglected case or lack of access to care in the US. You see growth of this, the lesions that I showed you earlier have become this massive tumor that invades into the orbit behind the eye. At this stage, really, the only definitive surgical option would be complete removal of the eye and the orbital contents. Next, please. However, in this particular patient, who was treated about 3 years ago, we had the option of offering chemotherapy, docetaxel cisplatin, combined with cemiplimab, which is a PD-1 inhibitor, immune checkpoint inhibitor. And you can see the remarkable response that this patient experienced after 2 cycles of this treatment. Next, please. Then he went on to have surgery. Next, please. And then the defect was reconstructed using modern oculoplastic surgical techniques. So this is his final outcome, and he has remained disease-free during our follow-up period, albeit relatively short, of approximately 2 years. Next, please. So I want to highlight the results of a translational collaboration we had with McKellar University, where samples of conjunctival squamous cell carcinoma from their cohorts, from their laboratories, were analyzed alongside samples from my practice at MD Anderson Cancer Center. This was mostly a genomic analysis, and time is short, but just some brief summaries. Number one is that tumor mutation burden seems to be on the high side. It's in the order of 30 to 40 megabytes per megabyte, mutations per megabyte, which is considered high. And the mutational signature that predominates is, in fact, ultraviolet exposure signature. And you can see that in the Ethiopian cohort, which is the left side of the panel, this signature is much more prevalent. We also did a comparison with the squamous cell carcinoma samples that were available in the Cancer Genome Atlas project from various different sites. And again, we see, if you see towards the right side of the panel, I'm not certain if you can see my mouse, conjunctival squamous cell carcinomas have a high tumor mutation burden equivalent to analogous to cutaneous squamous cell carcinoma. So this works in our favor if we want to use immune checkpoint inhibitors as part of the overall strategy for treatment of these locally advanced cancers that may present in sub-Saharan Africa. And another way to look at this cancer in terms of biologic markers would be to look at PD-L1 expression. And of course, overall, about 47% of conjunctival squamous cell carcinomas have PD-L1 expression. Next, please. So my take-home message and main motivation for coming to this symposium is to highlight, number one, we see a higher prevalence of squamous cell carcinoma of conjunctiva in sub-Saharan African countries, and perhaps in other parts of the world. For example, Brazil, certain parts of Brazil is subject to the same kind of prevalence. And we see this disease at a much more advanced stage with both life-threatening, quality of life-threatening, and vision-threatening, because the outcomes of surgery can be a lot more drastically different when these patients present with a later stage of disease. And our translational work suggests that this disease is a good target for immune checkpoint inhibitors, perhaps in combination with chemotherapy. And these would be appropriate for cases that would otherwise have orbital exenteration or are metastatic and are life-threatening. And my main pitch or my desire is to find partners to help coordinate clinical trials that would bring access to these countries for these drugs that are readily available in the United States and other parts of the world. And I hope to find partners to help me do that, coordinating centers and funding sources for this project. Thank you very much for your attention.
Thank you very much, Dr. Ismaili, for this wonderful work that really talks about the importance of interinstitutional collaboration and the importance of global oncology. We will move forward to our next abstract, which also talks about breast cancer. And this is going to be presented by Kenua Cecilia from University of Botswana, and it's titled Breast Cancer Pharmacogenetics in Botswana. Please, Dr. Cecilia Nonthondo, we're happy to have you here today. Talk us about breast cancer.
Thank you very much for the opportunity, and thank you very much for having me here. Yeah, as said, I am Kinewe Sicilian Tunto, a current PhD student at the University of Botswana. I'd like to first start by acknowledging my university as well as the Botswana UPenn Partnership, which is where I carry out all of my laboratory work, as well as the amazing organizers of this symposium. Next slide, please. As mentioned, I will be talking about breast cancer pharmacogenetics, and just a small background. It was well mentioned that breast cancer is one of the leading causes or leading cancers among women globally. So with many interventions and techniques that have been employed, such as immunohistochemistry and other in vivo techniques, my PhD study decided to work on the pharmacogenetics aspect of this breast cancer. So why pharmacogenetics? So pharmacogenetics basically studies how genetic variability influences drug metabolism, which ultimately talks about treatment outcomes. So in the pharmacogenetics profile of patients and the populations at large, there are three types of metabolizers. We have the poor, the extensive, as well as the rapid metabolizers. So just a quick overview, with poor metabolizers, it basically means when a patient is administered medication, their enzymes are not able to metabolize that specific medication, as thus they are prone to side effects such as toxicity. And then for extensive metabolizers, it's the normal pathway. A patient gets medication and they are cured, they get a therapeutic interval. And as for rapid metabolizer, it basically means that they do not get any, the medication does not reach any therapeutic interval, in a sense that immediately as the medication is administered, it is quickly metabolized and immediately excreted out of the body. So with pharmacogenetics, it is able to assist in certain aspects that could help in the clinical setting. We're able to assess drugs as well as metabolites plasma levels. We're able to assess therapeutic as well as clinical outcomes of patients. And with that, we're able to see toxicity levels as well as side effects. And with those side effects, they're able to determine adherence as well as compliance of the patients to the medication, as well as drug resistance and eventually survival. Next slide, please. So with this in our lab, I am currently working on, I have about 250 breast cancer positive formalin fixed paraffin embedded tissues. And these are retrospective. I have collected samples from 2014 all the way to 2019. So what happens in the lab, I carry those samples, those blocks go through microtomy sectioning, and from sectioning, they undergo DNA extraction. So from DNA extraction to DNA extraction, I have a panel of primer sequences as well as PCR approaches that have been designed. Most of them are in-house designed. So from there, I have PCR amplification. And lastly, we go into gel electrophoresis where we genotype all of these blocks and then the patients eventually. Next slide, please. And from the gel electrophoresis results, these are the results that we currently have. We're basically working on two genes, which are CYP2C8 as well as CYP2D6. So these are mainly genes that are specific for the types of drugs that our breast cancer patients here in Botswana are basically receiving. So for CYP2C8, we are looking at the STAT2 allele, and then this is an enzyme that metabolizes the chemotherapeutic drug paclitaxel. So highlighted in blue, I have highlighted the genotypes that carry the defective allele. So from the results that I have so far, I found that 8.7% of these patients do carry this defective allele. And these results are comparable with a study that was conducted in 2016, but on some of the Botswana populations. And then moving on to CYP2D6 star 4, I have found that there's 2.9% of these patients that carry this defective allele. And then this is also comparable with some of the African studies that have been conducted. And for star 17 was found a 30.4% of these patients that do carry this defective allele, which is comparable with some of the African populations that have been studied and genotyped. Next slide, please. So as in discussion and just trying to conclude, as mentioned, that this is just a preliminary study. So we found a prevalence of these 3-star alleles that have been working on, 2.9 for star 4, as well as 30.4% star 17 and 8.7 for star 2. So it is possible to estimate a 41.9% of reduced enzyme activity for tamoxifen metabolism, looking at CYP2D6 enzyme. And it also possible to estimate a 19.7% reduced enzyme activity for paclitaxel metabolism of these patients that are receiving this medication here in Botswana. So as mentioned, there's still current work on additional African SNPs, namely STAR2, STAR29, as well as gene copy number variation, which will help refine the expected metabolic phenotypes of tamoxifen. And in conclusion, there's evidences that show a non-negligible rate of these subjects that are carrying the genetic variants that are conferring slow or altered drug metabolism. And this African data that is provided can be used to establish priorities in investigations with the ultimate goal of being to enhance personalized treatment approaches, thus improving survival outcomes of these patients with breast cancer. So just to highlight more discussions and just in depth, I have a poster presentation May 9th. And with that, I would like to thank you very much for this opportunity. Thank you.
Thank you for presenting this wonderful job in Botswana on breast cancer. And we're moving forward to our next session, which is called I Have the Courage, I Prefer to See a Doctor. A qualitative exploration of Ethiopian women's hesitancy to screen for cervical cancer using HPV self-sampling. This will be presented by Nirma Rahman from City University of New York Graduate School of Public Health and Health Policy in the United States. Please go ahead. We're happy to have you here talk us about this screening phase for women.
Thank you for the introduction, Maria, and for this opportunity. I'd like to mention that this research is done in collaboration with the Albert Einstein College of Medicine and the City University of New York School of Public Health, as well as other partnering institutions, including the University of Arizona and Adama Medical College. Next slide, please. This study takes place in a large urban city known as Adama in Ethiopia. Here, cervical cancer screening uptake remains low, about 14%, despite efforts to increase access to preventative services by the Ethiopian government, which have been using the VIA screening method. The VIA method is conducted in a health clinic by a physician. Besides VIA, HPV testing is found to be a safe and easy approach for self-sampling collection in many global contexts, though concerns exist among age-eligible women. Understanding these nuanced perceptions and attitudes towards HPV self-sampling from an Ethiopian perspective is important. This qualitative study explores the perceived pros and cons of HPV sampling so that this approach can be tailored to the cultural and social context of Ethiopia to increase cervical cancer screening uptake. Next slide, please. So in May of 2022, 4 focus groups were conducted with 50 Ethiopian women each to discuss their perceptions towards cervical cancer and cervical cancer screening methods. These focus groups were 3 hours long and guided by Ethiopian community health workers who are trained in qualitative research and focus group methodology. The groups were conducted in Amharic, a language in Ethiopia, and participants were compensated for their time. Participants were shown educational videos on VIA and HPV methods. They were prompted to compare the 2 modalities and discuss why they like or dislike each. Audio recordings were translated and transcribed, and these transcripts were coded by Deduce software. Content analysis was conducted to identify major themes contributing to hesitancy. and direct participant quotes are used to describe the top factors in HPV screening hesitancy under the codes The Cons of HPV Self-Sampling and Awareness, which participants used to describe what their hesitancies were and how this has tied into their awareness of cancer and screening. Next slide, please. Considering the demographics of this group, participants were about 34 years old. Most had some formal education, most commonly high school education, and 70% had never been screened for cervical cancer. Within the awareness code, we see that some Ethiopian women reported a lack of knowledge surrounding cervical cancer and the existence of HPV self-sampling as a screening modality. Others expressed concern that a lack of knowledge surrounding the disease and the screening process would manifest in fear or reluctance to be screened. Participants believed there was a general lack of awareness about the HPV self-sampling procedure within Ethiopia, and that women living in rural settings may have even less awareness. For the cons of HPV self-sampling code, women are concerned about the wait time to receive their results, often after submitting their subsample, and there is also a lack of confidence in their ability to insert the self-sampling swab following the sampling instructions because there is an educational aspect as well, such as doing the counting motions themselves. And I'll give you a few seconds to take a look at these quotes as well. In conclusion, to promote cancer screening services in underserved communities such as in Ethiopia, it is imperative to understand the major factors that influence screening. Focus groups reveal that the reasons women may be hesitant to screen for cervical cancer using HPV self-sampling and education and screening interventions should address these concerns and self-described knowledge gaps to empower patients to make informed decisions about screening. The women were concerned with self-efficacy to take the sample correctly. They liked the instructional video and they wished for even simpler instructions, especially considering lower literacy level individuals. And other recommendations include tailoring education and services to lifestyle, such as highlighting no-cost screening for low socioeconomic populations and ensuring that screening services are offered at convenient locations and days or times to accommodate family care responsibilities and daily patterns of women in Ethiopia. So that's my presentation. Thank you for your attention and the opportunity to present.
Thank you very much, Dr. Rahman, on this wonderful presentation concerning cervical cancer screening. We're moving to our next presenter. We're going to see Dr. Anjali Mishra from Creighton University in the United States talking us about racial disparities in pediatric patients with acute lymphoblastic leukemia and NCPD analysis. Please welcome to this session with this wonderful information about pediatric cancer.
Thank you so much for having me. I'm excited to share this presentation with you all. So yes, my topic is about racial disparities in pediatric patients with ALL. We use the NCDB database to conduct this analysis. Next slide, please. So ALL is one of the most common types of pediatric cancers. In the pediatric population, leukemias make up 28.5%. So it says roughly 1 in 3 will have some sort of leukemia, closely followed by CNS tumors. And then amongst the leukemias, you'll see that ALL is the most common one, followed by AML. When you look on the official websites, it says that ALL usually peaks between 2 to 5 years of age, so affects the younger population. And then the American Cancer Society also notes that it has a higher risk in white and Hispanic children compared to Black and Asian American children. Current existing studies, which surprisingly, there actually has not been a lot of investigation into the epidemiology of this, but there have been 2 main studies that we at least reference, and one of them kind of comments how Black and Hispanic children do have worse survival compared to non-Hispanic white, and they say that also lack of private insurance and some of these other factors associated with it. This was a retrospective literature search they did. And then there's another database study that actually says that there is the difference in racial disparities is actually starting to improve and that it no longer really exists. And so with kind of these conflicting information, we decided we should do an updated analysis of the racial differences in overall survival of pediatric patients with ALL. Next slide, please. So we conducted this retrospective cohort study, identified pediatric patients, so 0 to 18 only, with ALL. The NCDB gathers data from over 1,500 hospitals and facilities across the United States. And then we categorized by race. If anyone is listed as unknown or other, we excluded that. We created subgroups based off of non-Hispanic white, non-Hispanic Black, Asian. We combined all of the East Asian, South Asian, Southeast Asian countries and did that as one subgroup as well. And then Kaplan-Meier and Cox multivariate was used, and this was de-identified data, so it was exempt from IRB board review. Next slide, please. So overall in our results, what we found was that there was still a very significant disparity. We found that Black pediatric children did have worse overall survival. They had worse 5-year survival. And then also after we accounted for comorbidities and multivariate, these differences did persist. We also compared non-Hispanic Hispanic children compared to non-Hispanic white, so by that ethnic group, and we also found similar differences there. In terms of the actual comorbidities, we did not find a significant difference in survival based on sex or insurance type, but we did find that medium income quartile was associated with improved survival, as well as having certain comorbidities was associated with worse survival. So next slide, please. Ultimately, what we saw was that these differences that some studies have said have been improving or disappearing have in fact not disappeared or improved. We see that Black patients continue to have inferior overall survival and greater hazard ratios compared to white pediatric patients with ALL. Because our data was looking from 2004 to 2020, we looked at it in subgroups. And so we divided it up into 5-year chunks. And we found that over time, the overall survival between subgroups has been improving. So as we see improvements in treatments, there has been a remarkable improvement in overall survival across the board. But when you look at the specific subgroups, there are these disparities that are quite significant that do persist. There have been existing studies that provide justifications to why these disparities may exist, which can be discussed more so during poster presentation. But some of these justifications include lack of access to clinical trials, differences in language barriers, cultural beliefs, financial stress, as demonstrated by how the impact of median income quartile affects survival, amongst many more factors that may be at play. So ultimately, we find that AL overall survival, although has been showing improvements when we look at the specific subgroups, especially broken up by race, those disparities continue to persist, which is quite concerning. Thank you so much for having me, and I look forward to discussing this research and what we found and more justifications and discussion as to what we can do for this at the poster presentation.
Thank you so much for this wonderful presentation. I had a problem with the connection. It's really important to see these highlights on racial disparities among pediatric population. And we're moving to our last presentation done during this session, which is patient financial well-being and access to cancer treatment during wartime. This is going to be presented by Dr. Taras Ivanjovic from Ukraine, and we're very happy to see this topic during our poster session. Welcome to this session, please.
Thank you for the introduction. Welcome. Today I will talk about the complex relationship between financial constraints and access to cancer treatment in the Ukrainian context amid the ongoing war. The research was collaborated with Ukrainian doctors from all around the world. Next, please. Our focus is on unraveling the impact of patient financial well-being on access to vital cancer treatments set against the backdrop of Ukrainian struggle during Russia's invasion. In October 2023, we undertook a comprehensive survey encompassing 522 cancer patients hailing from diverse regions across Ukraine, including areas perilously close to the front lines of conflict. Our primary objective was to dissect the nuanced relationship between financial status and the ability to access essential care services, particularly within the framework of Ukrainian Universal Health Insurance, UHS, and coverage with on Stanley shoulders the burden of most cancer-related expenses. Our study cohort predominantly comprised women with representation from various geographic strata, including Kyiv, this is capital of Ukraine, regional centers, and smaller town villages. Next slide, please. As for the level of well-being, 34% have enough money only for food, and 35% have enough money only for the most necessary things, and 25% have enough money for everything they need, but not savings, and only 5% of patients in our study live in full prosperity or make savings. The predominant type of cancer among respondents included breast cancer, colorectal cancer, cervical, lung, and lymphoma. And the most common treatments among the respondents were chemotherapy, surgery, radiotherapy, and hormone therapy. Target therapy was recommended for only 6% of patients and immunotherapy for only 2% of patients. 11% said they changed their place of treatment to get some medication or procedures for free. Most often this was done by patients from Kharkiv. It's the closest city to the front line during our war. Next slide, please. While approximately 46% of patients availed themselves of all diagnostic procedures facilitated through UHC, a substantial cohort had to bear the financial burden for some of all diagnostic modalities, notably including CT scans, MRI, PET-CT scans, and biopsies. Only near 10% of respondents reported unofficial payments for diagnostics depending on the type of diagnostics. Among unofficial payments in public healthcare facilities for diagnostic procedures, the first place is occupied by biopsy payments. Next slide, please. Our analysis unearthed a dichotomy in treatment coverage, with roughly half of the patients benefiting from UHC coverage for chemotherapy, radiotherapy, and surgery. Among the subset of patients compelled to navigate the maze of out-of-pocket expenses, the spectrum of financial burdens varied widely, encompassing from surgical instruments, cancer medication, and even payments aimed to circumventing treatment delays. Since near 90 were in treatment for cancer at the time of the survey and 65% were diagnosed less than a year ago, we can say that this study may represent access to treatment among cancer patients in certain areas during the full-scale invasion by Russia in Ukraine. We see that access to cancer diagnosis and treatment remains high despite the war. At the same time, we found that the war has affected the ability of some patients to receive treatment, especially in Kharkiv, which is closer to the front line. For example, more patients in Kharkiv reported delayed on interrupted cancer treatment due to the war, as well as delays of more than 2 months before surgery, radiation therapy, and hormone therapy, but not chemotherapy. A larger proportion of patients in Kharkiv reported paying for surgery, likely due to a lack of surgical instruments and moving to another city to receive free cancer treatment. At the same time, people who report that their income is only enough for food or necessities are more likely to be diagnosed with advanced or metastatic cancer. So thank you for the attention. I will also leave my email in the chat if anyone has any questions.
Thank you very much for highlighting the unique challenges that treatment of cancer has during war times. We're very happy to finish this session. I would like to thank the presenters that came from 6 countries covering 5 areas of cancer control continuum and really highlighted our theme this year, which is collaborating for impact. I invite you to see all the presenters as well as other accepted abstracts these years on the Gather on Thursday, and you will be able to meet the authors and have a more profound conversation on these studies lead on global cancer research. I would like to thank attendees for joining today, especially thank Dr. Kalina Duncan for her opening remarks. And note that I think really that the HPV vaccination and cervical cancer screening in India today really remind us of the importance of multi-sector collaboration. In addition, our oral abstract today included very important and highly incident cancers such as breast cancer, cervix cancer, and prostate cancer, but also very difficult to treat neoplasiums such as pancreatic cancer. And they really highlight the disparities we still have not only in adults, but in children, and the unique challenges that cancer treatment may have in low-income countries and special situations such as war. We would like to welcome the attendees for tomorrow, which will be our 3rd day in the agenda. The second oral abstract session will cover also global cancer control, and it's due tomorrow. During the second scientific session, we will hear from the U.S. Latin American Caribbean HIV, HPV, Cancer Prevention Clinical Trials Network, as they discuss how they've worked together to successfully accrue patients and are building sustainable infrastructure in the region. This is really a model of cancer care and something that we would like to mimic not only on HIV and HPV-related neoplasm, but really in every single cancer. If you're unable to join tomorrow, please provide us your feedback. We will show on a slide by QR code. You will be able to complete the post-conference survey. And that's really helpful for us to improve our planning for next year. We're really thankful for all your time during this session. It's really a very important time for global oncology and to highlight projects with, global cancer impact. Thank you very much for your time. And again, please help us answer that survey. Thank you for every poster presented, and see you tomorrow on our 3rd day. Thank you very much.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.